Hello, dear friends from all over the part of Central and Eastern Europe, at least, and not only. Also, we have seen we have guests from Switzerland as well. Welcome everybody to our webinar that is guested by our host, KaVo. We are saying also hello to our host, Dariusz Mishkevich. Hello, Bogdana. Thank you uh, to be with me today. I also have forgotten to say officially hello. Welcome, everybody. Welcome. And I have to thank you that you are beside me and my colleagues from KaVo today for another presentation. This is our third one in this collaboration. Me as Dr. Ivic Roxana and KaVo. We had Romanian webinars, we had in English as well on adhesion, and this is our second subject, let's say, about dental composites, the restorative ones. Hello, Stan. From wherever you are, everybody. Uh, Hi from Romania, Laurențiu. Bună, hello, Laurențiu. Also, I'm thinking to my colleagues that are helping us with KaVo locally, Laurențiu Beleț and Costin Marcu. Costin has a name day, let's say, today, and so have a beautiful day. Ruxandra, hello from Bucharest, of course. I miss Bucharest, but in a few days I will be over there together with my colleagues in my dental office, Caraili Dent in Bucharest. Elisabetta, hello. And I'm quite honored to be today also with you and my colleagues. We are facing some times because of this epidemiological context when we are more close to each other as ever, because this digital platform or platforms are making us easier days for online education. Maybe last year we said it's not the moment for online education, but right now we can say it's the present and future for sure on online area to educate ourselves as much as possible. And this time was quite an efficient time to get more and more, let's say, focused also on the knowledge of getting of being a better dentist, let's say. Right now, I'm far away from the chat area. I have entered my desktop presentation. So from time to time, I will go to the chat area. If something, let's say, it's not understood very well by you, you can write down. Officially, at the end of the meeting, I will try to make it as short as possible, 1 hour and a half, 2 hours. Maybe it's going to be as in the other days. We are going to have some questions and answers from myself, of course. Questions that I will see in the chat, but if something is going to skip from my view, also my colleagues, Dariusz and the other colleagues from Romania are going to help me to answer to your questions. I know my topic is quite large when I'm talking about restorative composites. And I have said how to harmonize aesthetics and functionality in composite restoration tips and tricks. For sure, as a practitioner, you are on this webinar with me, wanting to answer to some unclear aspects of direct restoration with the composites, with these adhesive aesthetic materials. I will try to be, let's say, through some clinical cases more specific, and if something is not clear, you can ask me. As I said from the beginning, my name is Roxana Ilic. I'm a dentist, as most of you, maybe you are. I don't know if we have students with us also today. But I'm also working in the academic area. I'm a lecturer in the Department of Prosthetic Dentistry and Dental Materials. That's why I am focusing on properties, advantages, disadvantages, and clinical protocol when using different types of materials. And right now, when I talk about composites. I have also a competence in pediatric dentistry, as I have already two kids. And I focused as well on a preventive and prophylactic part of dentistry, together with some colleagues that I think I have seen over there on the list, Ruxandra. And of course, we are looking forward to mix restorative aspects of the dentistry with the preventive part of this of our practice. Today, I wanted to gather in a very short time that we have together the essence of some aspects when we talk about dental fillings. We are talking about diagnosis, of course, and because we collaborate today in this webinar with KaVo, I have used from them from KaVo a very interesting device that is based on near infrared um, transmission waves, and it's used for caries diagnosis, including early caries diagnosis. That is beneficial for minimally invasive aesthetic restorations. Also, as many of you maybe have seen from last week's, I have, let's say, a kind of passion towards adhesive systems and adhesive materials used in dentistry. And today we are going to focus um, also on universal adhesives, the last ones that Kerr has promoted, and we are using it already in the dental offices in the last few years. And not only this, but also on the traditional and gold standard ones. And when we talk about adhesive composite restoration, of course, we are talking about different composite materials, from the conventional ones, layered ones, to the new bulk filling composites that are different from manufacturer to another one. But KaVo has a unique one, let's say, it's sonic field, activated by the sonic waves. So I think it's going to be interesting for you to know about it if you don't use it yet. And of course, because KaVo has Have, let's say, department that is manufacturing very beautiful mattresses, wedges, and different other accessories for dental fillings, I'm going to use them in some clinical cases. I'm collaborating with KaVo in the last 15 years already. In 2006, I had my first presentation together with SPOFA Kerr. But now my last hands-on workshops were on sonic fill, on Harmonize, the campuses that I presented in this slide, together with their fantastic adhesive systems. When we are talking about the clinical protocol, everybody knows from students to the most experienced dental surgeon that we have to go through some very precise steps that we don't have to rush and to take to pay attention to many aspects of the steps. We are thinking about diagnostic, about color matching, cavity preparation. Even though when we are talking about cavity preparation now, it's better with the composite than with the amalgam. The isolation with the rubber dam, you're gonna see that also during my clinical cases. I'm using rubber dam only with some very few exceptions when I make those pictures with my students. in in another condition than in a normal dental office. Um, we have to apply matrices and interdental wedges. I love the wedges from Kerr. We have to apply very precise the adhesive systems. We have to know all of the generations. We have to know the advantages, the disadvantages of these adhesive systems. And of course, to apply the composite and to restore the morphology of the tooth, because shape and function of the tooth are hand in hand. So only together can be a success. Finishing and polishing, of course, the structure, the surface aspect is interesting also for the success and for less bacteria on the surface of our fillings, so less secondary caries, and the monitoring of these fillings, and our diagnostic device that we are going to see in the next slides, like DiagnoCam, can be quite useful in this part of monitoring our dental fillings. We are in a moment when the dental amalgam is not anymore the VIP. Let's say, fortunately for us, from some kinds of aspects, especially from the minimally invasive point of view, because when we use composites, now we are more conservative to our dental structures, and we go with the cleaning of the carious lesions only, not making any more those geometrical shapes of the cavities. So indeed, we are minimally invasive, and we can use during the lifetime of a patient all types of restorations, from fillings to dental crowns, and then if it's indeed needed till the end of the life of the patient, implants. But right now we are talking about this Minamata Convention is the one that doesn't want to use anymore the mercury in all kinds of fields in the human life. And of course, dentistry, it's an area where mercury is used in the dental amalgams, but globally, it's already ratified this document that we have to take some decisions, each country in the world, also the European ones, and the Romanian ones already had a motion and a decision that is passed to the Ministry of Health, and we are looking for the final decisions, let's say, that we have to take some ideas into practice. So we have to set national objectives aiming at dental caries prevention and health promotion, minimizing the need for dental restoration. So we have to diagnose as well, from the start, the dental caries, not only the visible to the eye, also the invisible caries lesions. And the device that talking about, DiagnoCam, has this benefit, let's say, compared to others, to set some national objectives aiming at minimizing the use of dental amalgam, of course. We don't use it in jars anymore, the dental mercury and the powder, but only, of course, as you use it, all the European countries has in the capsules. To promote the use of cost-effective and clinically effective mercury-free alternatives for dental restorations. And this is our aim, and Kerr's aim, to have this kind of composites that can be putted very efficiently, very less time consuming, so in a very rapid way, not let's say, harming the properties and success in time of these restorations. So the composites that I'm trying to present you today, I would say, enter in this kind of idea of cost-effective and clinically effective composite restorations. And of course, we have to encourage professional organizations, dentists, as you are in front of me, dental schools, to educate and train the interprofessional students on the use of these mercury-free alternatives, and on promoting best management practices. So I would say our webinar today is quite on these ideas of this Minamata Convention. So we are on the good path with our materials and our devices and our technologies, because we are talking right now about a progress, an incredible progress of the technologies, and not only on the materials, on the adhesive parts and aesthetic aspects of the materials, but as well on the functional of the devices, of diagnosis, of diagnosing as early as possible the caries. This is the device that I have started using it in the last years from KaVo Diagnocam, and that is using transillumination technology to support the identification of occlusal interproximal. I will have one case for today, interproximal clinical case, and of course the not only the underneath recurrent carious lesions, but also the marginal carious lesions, and of course the cracks that are besides our composites. Let's say depends on the combination that we are making between composites, adhesive system, uh, thin or not dental structures, and light curing, of course, and dental matrices and wedges. All this complex could link to the presence or absence of the cracks near our composite fillings. This is only to make you an entrance in this area that KaVo starts to be very proficient in diagnosis devices. This is a diode laser that is producing near infrared waves that are going um, from um, from down to top of the tooth. um, this is a transillumination, let's say, but with digital images that can help us and our patients to see the lesions that we have, the carious lesions, especially that we have, or as a primary carious lesions, or as a secondary or underneath carious lesions, besides our materials or not. So this is a device, a minimally invasive, we can say, because has non-ionic radiation. It's more biocompatible to our body, also for children, for pregnant women, and it's preferable in some clinical cases when compared to the radiology, to the X-ray investigation. Um, this device is very adapted to this international caries detection and assessment system. If you would like to see what the professionals, the universities are using for caries identification and classification nowadays, you could go to this website, digitas.org, and you can see how you can code, how you can, let's say, put some codes on each of your tooth and surface regarding to the presence or absence of the fillings on the tooth, sealants or not, crowns or not, missing teeth or not. Or when we are talking about caries, we have, let's say, a classification for the zero, no caries on the surface, so very healthy tooth. One, when we can see only when we blow up the air on the tooth, we can see the caries lesion, otherwise not. Um, on a tooth, whether it's wet, whether it's dried, if we see an early caries, so we can say it's a 2 point enamel caries. And if we see already a mirror cavity, so it's the number 3. coat, if we can see the dentin already, because the enamel has been interrupted, we put the 4 coat. And of course, 5, we have a large visible dentin already, or very extended with this, let's say, large areas of dentin exposed on the 6th codification. Of course, if you want to see it, there are also articles and books already on this new classification of caries. This device, the AgnoCam, have the ability to see what we can't see with our eyes in some situation. For example, over here to the marginal ridges, we can see a caries on the 1.4 tooth distally, even though on the buccal part we can see a brown spot, and we could codify it as a 0 because we have no filling on the tooth, and number 2, because we have a visible brown stain on the distal part of the tooth. On 1.5 we have no visible caries at all, mesially and distally. These are some images that we can see with this device, that it's very interesting from KaVo, this DiagnoCam, and we can see on the 1 point mesially, even without the eyes, we couldn't see this demineralization of mesially of the premolar. But distally, we can see already that with this device, we can see a brown area on the enamel, on the enamel dentin junction already advanced, that it is a real carious lesion. Of course, on the 1.5, also only with the AgnoCam, not with the visible eye, we can see that also on the proximal parts, the enamel has started to get acidic and demineralized. So these spots that we can't see with our eyes, but with the AgnoCam, by preventive treatments, fluoridation, for example, can be healed, these kind of early caries, incipient ones. Of course, these are some images from our extensive studies on some clinical cases right now, because it's only an idea of the diagnosis that we can do to our patient. I selected only a clinical case. But of course, we wanted to see in comparison also with the Diagnodent pen, but I didn't put it here. Right now, it's another very good device to identify caries. But in comparison with the bite wing, how we can see that distal caries lesion. The agnocam in this case, we would say that would go very well to diagnose these proximal distal caries with or without bite wing that is not recommended, for example, for a pregnant woman. Of course, you wanted to see only, we selected only the distal part of the first premolar to get inside and see the extension of the caries lesion, of course, and to treat it, let's say, as a routine to take out the caries lesion and to fill it with an adhesive composite filling. Of course, the caries lesion went also in the dentin. We have to clean it, of course, a little bit in the dentin. We have used, as to every kind of filling in composite, a rubber dam. In this image, we could see some accessories that are from Kerr. For example, I have used the Optidam posterior rubber dam. They have the easiest rubber dam to use in the dental market, I would say. I use it, me as a student, also my students. In my last year of university, I had it as well. And it's very simple because you can cut down some protuberances that are going from outside the morphology of the dam. So it's very easy. You don't need a clamp, let's say a forceps, or to pinch the rubber dam, only to cut it with the scissors. and it's the anterior optidum or posterior optidum. This is a posterior one used in conjunction with they had, but they don't have it anymore, this elastic silicone wedge on the mesial part. I found it very useful. And distally, I have put it the wedges, the latest, the most narrow wedge that we can use, in my opinion, in the market. The Sycamora wedges. They have a kind of assorted kit with seven types, at least seven types of wedges. And this is the last one, the blue one, the light blue wedges are the smallest that I'm using it already in my pediatric patients for children. And we can see how good in premolars, and we know premolars are not easy to an area to adapt with the mattresses. We adapted quite well these wedges. In order to, as you all know, we have to push as much as possible these wedges in order to compensate for the width of the mattress proximally. When we put away all the mattresses and the wedges, uh, the teeth to come together and to have very tight contacts between the two premolars. Over here we can see the last matrix. It's a circular matrix from a curve, and it's a very good one, especially for students, but also in my dental office already. And these days of epidemiological context, I can say I do open heart recommend it. We can adapt it. Is a very, let's say, contoured proximal this circular matrix, and you can adapt it cervically very well with these very good wedges. So this team matrix, this metafix, and the wedges could make you the best fit on the cervical part of the composite and shape. Of course, this metafix is a matrix that comes in three sizes, let's say. For maxillary molars, I would say they are the biggest ones, medium size that I buy the most often, one type, and the little one for premolars. But the medium size also goes for molars, maxillary or mandibulary. The biggest one I would use it more for a mandibular, big constitution molar sizes. Over here, of course, we can see these shapes in the rubber dam. The adaptation for the tooth. This is dental filling with sonic fill. It was the first generation of sonic fill, in 2010 that appeared. This is a clinical case. This is a, let me see, no, this is sonic fill 2. This is sonic fill 2 that I'm using right here. It's a consistency a little bit higher than the original sonic fill. And you can see it's an injection type composite. You can inject it directly onto the cavity. The head of the sonic fill microcapsule is very tiny and ergonomically shaped to go very well, even in the most distal cavity in the third molar. And you can see after finishing and polishing sonic fill 2 how integrated it is as an aesthetic, but also as a shape point of view. Diagnocam also reveals us that when we are looking to this tooth and filling or composite with the most modern device, let's say, of investigating some dental tissues and materials, like it is this technology of digital uh, with this transillumination with near infrared. the aspect of the composite is quite similar to the to the tooth, to the natural tooth, and this is a quite advantage because we can monitor this kind of feelings through the time, and we can do how many images we want, to 3 to 6 to 1 year. It doesn't matter how many evaluation of that tooth we can do, because it's not a harmful evaluation for our patient. And if they are the same image, the composite and the tooth, if secondary caries will appear in 3 or 5 years, this is a statistical, let's say, idea, fact, in the literature, we can see any change visible immediately in this evaluation. So this was about diagnostic, a little bit to make some specific for today from KaVo to our adhesive composite fillings. About color matching, of course, this is another 1 day, let's say, presentation or cavity preparation. I will leave for aesthetic dentistry the second part, and the cavity preparation for my colleagues to the conservative department to take care. Because now we are in the times of bioactive or remineralization type materials, um, starting with the glass ionomers, but going more further to let's say that calcium silicate preparations. So the cavity preparation has another story when talking about dental materials. But we have to say that composites indeed made a revolution for all of us in our dental offices and for our patients, because now we are the most minimally invasive as ever we have been in dentistry, because we are taking only the caries lesion, and we are taking advantage of the adhesive system in order to adhere our composite. At this moment, only the flowable composites, I have put it a clinical case at the end of the presentation, for example, with Vertis Flow from Kerr, starting with 2010, has made the first steps as a composite to self-adhere to dentin and enamel. And indeed, I have 10 years already clinical cases with this Vertis Flow, and it's a material that is making me very optimistic that one day one manufacturer, and very soon we hope, is going, I hope also to be Kerr, that this manufacturer, to give us, let's say, composite, an injectable composite, restorative from down to top, to restore all our morphology and to self-adhere. Of course, right now we know the glass ionomers have this self-adhesive property, but the bone strength of the glass ionomers is very low compared to the dental adhesives in combination with composites. So we are looking forward also the composites, and to have these self-adherial, self-adhesive properties when we put them into a cavity. But it's not now the time. Of course, we need these accessories that I have said, and KaVo have this manufacturer from Switzerland that is giving us these accessories from Bioggio, from Lugano. I remember the place when I have been 10 years ago. We apply, of course, underneath the dental adhesive systems and the other steps that I have told you. The composite is very linked to the adhesive system and the let's say the uh, how strong it is, the dental structure around, because if the adhesive system is strong, as is Optibond FL, let's say, but we choose a composite that is shrinking a lot, We could see the transmission of the tensions, of the stress, of the polymerization shrinkage stress towards the tooth, and we could have the cracks around the tooth, and maybe to distance cervically also, if we have also some occlusal problems. But if the adhesive system we are using is not performant in adhesion to enamel and dentine, then in time we could have this leakage, the micro leakage around the composite, so we can face it with a marginal discoloration, with carious lesions, secondary carious lesions that go farther in time towards the pulp, and give us some endodontic problems in time. Of course, if we have high shrinkage, or we put them not taking in consideration that every composite is shrinking, and we are taking up the adhesive on a very deep cavity, we in link with an adhesive system that used an acid etch on the dentin, we could have a post-operative sensitivity in that day, or till a few days on that patient. Uh, of course, when I am talking about dental composites and adhesive systems, um, I have made some research together with some very good clinicians and researchers of dental materials in Birmingham and Dublin in Ireland. Professor Fleming, Professor Burr, Professor Walmsley was supervising as well. And we have made some research on this kind of relation between composites, adhesives, and dental structures, and we have measured the cuspal deflection that the shrinkage of the composites is making, and of course the micro leakage that could come in as a secondary part around our dental fillings. We have made it in a laboratory, of course, with a dye, with a pink dye, but we have seen that the flowable composites are making less cuspal deflection, but on the micro leakage we have seen not a very statistical difference. Of course, we studied some types of polymerization protocols. Optilux 510, it's also a light curing, a halogen light curing that had more than 20 years of success. It's not used a lot anymore, but I still have it in my dental office. I have to tell you, and I'm taking it to my dental students when I need an extra light curing. So it's still functional, and it's still very how to say successful in these days of LED light curing units. And but we have made with many making many researchers, we have made a kind of a protocol in the laboratory to study the adhesive performance of the dental adhesives in conjunction with the composites that simulates the best compared to other research protocols at the moment, and it's quite considered a standard at this moment, this kind of protocol that Professor Fleming has made through around 9 researchers already. So I had 2 researchers part of the 9 that he has made so far. Um, when I finished my PhD, we had in 2010, we had, let's say, the 3 types of adhesive materials underneath the composites, and now we are talking about a self-adhesive composites as Vertisflow, I am telling you. The adhesive part of the adhesive system, we are using it underneath the composites. I already talked about this part a few weeks ago, and if you are interested, my colleague Darius will copy paste you the demo link of my webinar that focused a lot on the types of generation of adhesive systems. Kerr has indeed a tradition in the last, from the beginning of the adhesive dentistry, in the last 50 in the last 40 years, talking about composites, and the best adhesive system on the market starting 30 years ago, about etch and rinse adhesives, as the fourth and fifth generation, Optibond FL, respective Optibond Solid Plus, and self-etch adhesive systems from Kerr are from 6, 7, 8, 9 generation. We are talking about Optibond XDR, E Extra, Optibond All-in-One, and Optibond Universal. That's how they look, the adhesive system from Kerr. And I would point out that I would recommend the monodose presentation of these adhesive systems, because they are quite recommended, also in the last years in the United States, but also we as Europeans, we have this type of presentation to avoid the cross contamination between our patients. And in these days of coronavirus, also this kind of unidoses are very recommended. Not only the rubber dam, also this kind of unidoses are recommended for adhesives, also to have the best composition and properties from the adhesive materials and to avoid the cross contamination. And as I said about the mattresses, also a single use mattresses as Metafix are very welcomed, I would say. These are the universal and dental adhesive system from KaVo from Kerr. Optibond EXCR, extra universal, that is the, we consider it the ninth generation because it's the last one that has been refined by Kerr. And Optibond universal as well, that is an all-in-one with acid, primer, and bonding in the same bottle. Of course, each of them bottle or unidose. They are universal because they go both enamel dentin, they go both on dental structures and on restorative materials till zirconia material. And they are universal because we can use with the same adhesive, for example, as Optibond E Extra Universal, we can use one of the three adhesive modes. Let's say self-etch mode of this universal adhesive, so we don't use an acid separately. We can use a selective etch of the enamel in conjunction with this adhesive, or we can use a total etch approach if we have a dentin that is not very close to the pulp. This is, of course, a presentation as a synthesis that you can understand it more if you look on the presentation that I had a few weeks ago. Over here, I would emphasize that for direct fillings, the best one has been already, let's say, confirmed because he appeared in 1991, this Optibond FL, and has a very thick layer of 40 microns. That is the layer above, let's say, the dentinal structure. And this thick layer is very good to be an elastic buffer in order to save the adhesion between tooth adhesion layer and adhesion layer and the composite at its shrinkage and making tension on the adhesive interfaces. So this is a very useful adhesive in direct restoration that we are talking today. But when we are talking about the aesthetic class 4 cavities, for example, if we make a lot of finishing and polishing, we could see with time this layer of adhesive that has also HEMA could change it's as a white line, let's say, and also could change the color at the interface in time. It's protecting regarding caries because it's the highest level, let's say, fluoride adhesive with fluoride particles, but could aesthetically could be a problem, let's say, but in very, very few cases. It's the most used and the most reliable one, we can say, for the fourth cavities, for the traumatic cavities, and uh, the its bond strength to the enamel is the highest on in the history, let's say, of adhesives. So when we are talking about frontal area, this is the most reliable at this moment and most most how to say, proved adhesive system on the market. So from this point of view, on the frontal area, you are more than good to use it, but to pay attention to blow away the last adhesive layer as much as possible, to have it as thin as possible and not to interfere aesthetically. When we are talking about the other ones regarding aesthetics as adhesive systems, Optibond Solo Plus also is very good on enamel with a thinner layer, so it's very good to use on a lot of enamel with paying attention to deep cavities, this one, because this is the one that could give us some post-operative sensitivity, especially if we don't pay attention how to use it as an adhesive system of the fifth generation. And it's good in direct and indirect restoration. And Optibond XTR Universal and Optibond Universal have a thin layer, especially Universal one, Optibond all-in-one Universal one, with 5 microns the adhesive layer. So very thin, very good to use it in conjunction with the selective edge of the enamel, also posterior or anterior if we want, and very reliable as well when we add an selective edge of the enamel if we want very um, aesthetic and mechanically, let's say, as a fourth area cavity restoration is mechanically, let's say, stressed. These are the golden standards, in my opinion, and not only mine, in from Kerr, but they are the oldest ones. That's why a standard had to be proved in the last 30 years already. So these are the 30 years materials from Kerr, proved already on the market and in the dental offices and in the composite dental fillings. So Optibond FL and the microhybrid in this case, extended range Vita shades, as you say, Herculite. Kerr has all the Vita shades and many more other shades to individualize your beautiful composite fillings. Also, Optibond Solo Plus is it's the most bought, let's say, composite so far. That's why they were put it together in that anniversary, let's say, package. How universal is adhesion? Of course, the self-fetch approach, it's very good for the dentine. Where we have dentine, the best adhesive is the self-fetch one. So the universal ones are the perfect ones for the adhesion to dentine. But when it comes to enamel, to have a more reliable and trustful and long-term adhesion, not only me, but also the specialists would say that the adhesion of phosphoric acid etching is increasing the bond strength. On dentine has a longevity of the hybrid layer as a bonding in time. It's good to have the self-fetch approach more and to use the universal ones, for example, not the sixth and seventh generation that are a little bit older, because we can add also micro retention to this self-fetch chemical adhesion approach to this 8 and 9 adhesive systems. So I would use the selective edge of the enamel, where if we have the most aesthetic fillings and a lot of enamel, and if there is a lot of dentine, I would use the self-edge approach, and only if I can control the appliance of the acid edge on the tooth, I would put the selective edge in deep ones. When it comes to internal and marginal adaptation of high viscosity bulk fill composites, over here we have some composites that are like tetriglycerin or extra fill in let's say in syringes. But total also a high viscosity bulk fill composite, it's a sonic fill after the application, because during application sonic fill has an intermediate viscosity, is a medium viscosity, let's say, towards the flowable ones, but not so flowable. Especially the sonic fill 2 and 3 are more towards high viscosity, let's say, bulk fills, with more emphasis towards the mechanical properties, not only to the adaptation of the cavity. But it seems that it doesn't matter if we put a layered or a bulk fill composite. Also, the application of an acid on the enamel margin is beneficial for all the types of composites that we put. So a selective etch or a three-step etch and rinse, as it is Optibond FL, would be the most reliable, of course. Over now we have Optibond EXPR, that it's the adhesive system from Kerr, that I would say it's the adhesive system that is taking all the advantages of Optibond FL, but leaves you the flexibility and the freedom to put what adhesive mode you want on the cavity, the clinical case that you have. I have used, of course, in 2006, I have started my collaboration with Kerr, working with Premise, a composite that didn't disappointed me till the moment. And it's a nano composite, this Premise from Kerr, that is still on the market, but has a very high aesthetic level, many types of shades, very beautiful luster, and the longevity of the luster, let's say, but has a high viscosity. Ergonomically speaking, it's hard to a little bit harder to work with Premise compared to other composites on the market. Right now, we will see Kerr has gone towards, let's say, more ergonomically composites, to shape it more easily, as Herculate Ultra, or especially Harmonize, the last one. So here I use Premise and Optibond FL, the fourth generation, the gold standard, the most reliable old ones that is proved. Here I have one of my students that is already a dentist right now, with a nano uh, lateral incisor. We have this kind of approach with a wax up, with a silicone guided impression. And I wanted to use this Optibond FL in order to have the best adhesion to enamel, and in order to have the most reliable, the highest bone strength in this mechanically, also aesthetically, but also mechanically stressed area. And this is Premise when I applied it in use in the help. When you use Premise, you can put like a tac movement on the composite, and his thixotropic properties is making it more soft to rely on the index of silicone. Or you can use Compotixo from Havecare, that it's a vibration device that is using this property of thixotropy of composites to get more soft and let's say towards flowable consistencies. This was the enamel A1. This was a little bit of dentin, not to have about the darkness of the mouth, and of course again the enamel. No, we didn't use then the rubber down, because we have made it in the condition of the university. We had that silicone, let's say, protection from the back. And I can say that already 4 years of clinical performance, these feelings have already. So they are more than verified as a time. And even though the clinical performance is after 5 years, let's say, and our dentist is alpinist as well, growing on the highest edges of the mountains, not only in Romania but all over the Europe. As you know, we don't have at the moment only layered composites. To put a flowable as the first layer and then to put oblique shapes in order to build the proximal or occlusal area. But we also have bulk fill composites. Bulk fill means that has a layer that is more 4 millimeters that could be like cured on the depth of more than 40 millimeters. And we have on the market the flowable bulk fill composites as SDR from Densplay. We have the highly viscosity bulk fill composite that goes into syringes, as we know from 3MSP and other marketers. And we have the unique bulk fill composite, sonic activated composite that goes on 5 millimeter depth from bottom to the top from one application that mix the advantages of a flowable composite and I would say the advantages of high viscosity packable composite. I have used in some images, in my next images, a layer composite from Kerr, Herculite Ultra and Sonic Fill, the bulk fill composite. And I would say that I have used on some plastic composite, some epoxidic artificial teeth together with one of our colleagues, with Marilis Garzon, in order to compare to see advantages and disadvantages of these techniques. These techniques I put it into practice with all my dentists during my workshops with her, my colleagues during our workshops in Romania. And of course, we have put it also, even if it's an artificial tooth, as in practice, the optidam that I have told you, the optidam posterior, the this is the clamp that is from Kerr, that is a plastic one and the universal one. The scissor, of course, and to put the clamp on the tooth. Metafix as well, we put it on the tooth, and we use the adhesive protocol of Optibond Solo Plus, so the fifth generation adhesive. I also have some slides that are in Romanian. I have to change it for Darius. We have used Demi. We have on the market three types of Demi. Demi Ultra, the black one, it's the last one. Demi and Demi Plus. Demi Plus. Demi and Demi Plus are the ones that I also I have it in my dental office using it at the moment. And Compotixto that I told you, it's a device that is vibrating the material and is using the compotixotropic properties of the composite. This is the Herculite Ultra, let's say, aesthetic assorted kit that comes for the front area especially because it comes with the enamel ties with the dentin shades, the most used ones. The clear, the medium, let's say, translucency of that is needed in incisor of the teeth, and also with the most used pigments from Color Plus. Here has an 11 types of pigments in of Color Plus that we can use it in direct restoration, indirect restorations as well in the composite area, and the blue one and the brown, of course, for stains in the pits and fissures, and the blue one for the central incisors for the frontal area. Because they are so good to accessories, you will see in many packages with the composites from Kerr some finishing and polishing kits, like we see over here with the brushes with opti discs. These are the discs I prefer compared to others, and of course with the the little polishing devices that are very good from Kerr, and the ones that I don't replace with other market manufacturers, the opti strips. You will see them in white for in blue for finishing, or white for polishing. Of course, the adhesive protocol with Optimum Solo Plus is a total etch adhesive, etch and rinse in 2 steps. We put the 37.5%, 30 seconds on the enamel, 15 maximum on dentin. We wash a lot, we air dry, but to have a moist dentin, and we brush a lot of Optimum Solo Plus. We dry very good to go out the solvents, and then we light cure. So the action, the because we have matrices in clinical, we have to pay attention to wash very well this acid. When we put it separately, we have to wash it very well, also around the matrices, not to have post-operative sensitivity on the cervical parts to our patients, a sensitivity that was not before over there. The self-etch adhesives have the advantage of being very good sealants, let's say. So if the acid goes around, we the self adhesive properties of Optibond Extra or Universal are very good to seal these open the uh, cracks and the porosities and the demineralization that we have made with the acid. We have to have the moist, and this is the dentin. Also, as in the practice, what I recommend is to pay attention to these adhesive tips. I love Kerr adhesive tips that comes 200, I think, in one package. Sometimes I say I prefer to buy mini kits only to have these brushes, and advantages of the acid depends on the type of adhesive mini kit that I buy. But these applicators are very safe to put also the traditional adhesives like fourth and fifth, but especially the self-etch adhesives that are more acidic, and they have a lot of acetone, let's say, that would that could take the brushes out of the tip. But these that are from Care have a high surface to get with the adhesive, not to take down the that little part of adhesion that is taken from the bottle, and or we can take the adhesive as it is correctly from the those little blisters that Kerr is giving us, and we can brush very safely with these applicators, not with others from other no-name manufacturers that could take down the brushes. The acidity of the adhesives are taking us down the brushes to other manufacturer tips. And we light cure. The light curing of adhesive layer and the light curing of the composite in our filling is crucial, because also the quality of the, of course, the quality of the light curing unit is very important to be checked up periodically to our light curing units, and to have a very good performance of the light, and to have the light guide as close to the tooth as possible. Also, Kerr has an advantages regarding these times of pandemia, because they always have to their dental units individual sleeves. So for each patient, you can put your his own sleeve over the optical guide, and we can go almost in contact with the tooth, because when the adhesive manufacturer is telling us a light curing goes 5 seconds, like for example, for an adhesive, I would recommend to double the time of adhesion on the adhesive layer at least. Because also the adhesive layer goes in the lab when they make this performance of the adhesive unit, the light curing unit, they are putting the 1 millimeter distance maximum, the adhesive and the light. But in the clinical routine, we have very deep or medium or deep cavities, and according to the deep of the cavity, we are putting extra seconds during light curing. We have to link together the monomers in the adhesive layer, in the hybrid layer over there where it's stubborn, the monomer to get together in polymers, and we have to pay attention to the light curing of the adhesive layer, of course, to the composite. And when we are talking to the composite, we are going to make the trans illumination light curing as well, occlusal, buccal, and distally. Sorry, just a moment. This is the adhesive layer after light curing, so we have to see it very well on the enamel and on the dentin. So we can imagine over here to be uniform as possible. The Herculite Ultra Nano Hybrid from Kurt, that I use it in the layered style, looking with an eye to the style Italiano recommendations. Let's say we recommend, especially when you have also from other uniform manufacturers, but also with Optibond Universal, when it's an all-in-one adhesive, let's say, or when it is like Optibond Solo Plus, the last layer of the adhesive, it's acidic because it comes with the oxygen in the area and it's inhibited that layer of the oxygen, so it's not polymerized. Even if we have tried with the light curing as much as we could, that acidic layer, it's good to be covered with a very hydrophobic material. So I would recommend also, because from this point of view, but also because of the acidity, but also because of the permeability of the adhesive layer when concerned to the composite above and dentin, that it's a lot underneath. I would put a layer of flowable composite. Also the flowable composite that is very hydrophobic, let's say Herculite Ultra Flow. It's more hydrophobic, let's say, as the Vertis compared to Vertis Flow, that is more hydrophilic, but with indication in other areas more comfortable than in this layer liner. I would put it also to make the more round the corners and to make a uniform base of the cavity. The first layer of composite, it's recommended to have a more good adaptation of the highly viscous composite that comes above, as there are these layered composite, high viscosity layered composites, even if it's premise, even if it's Herculite Ultra. We have put it over here, the Herculite Ultra in unidoses, because also I would recommend, according to this pandemia and in general aspects of avoiding the cross contaminations, to use the unidoses of composites. And this pushing of the material with the pistol that also Kerr and other manufacturers have, we are also putting in activity the property, we are activating the thixotropy of the composite. So we are making it more soft and to be more adapted to the cervical part of the cavity. We can use, if the cavity is narrow, we can use, as also some others colleagues said, to put the dentin shade till the level of the occlusal cavity. So to put the dentin shade. If we have a very large cavity, buccally speaking, so could interfere the dentin saturation visibly as aesthetic importance, then we should take another technique. We should use the technique of putting first the enamel, and to put the enamel from up to down 1 millimeter margin, let's say, of enamel, light curing, and transform a cavity of two type into one type cavity. But now in this image, we have put it already, the flowable, we light cure it already, and we put the dentin towards the level of the occlusal cavity. We light cure it, we shape it, we condense it as much as possible. We have used here Compotixo. more we have softened and adapted the composite because the tip is vibrating. And of course, when we have a very good adaptation to the cavity, we are light curing occlusally because we have a metal matrix in this step. But at the end, we are going to put also transillumination from both sides, buccal and lingual. In the other step, after the dentin part, we have put it the enamel margin. We have made from XRV Ultra enamel the marginal ridge, light cured, and then we have made a successive reconstruction of the cuspids in order to make a more aesthetic restoration. This kind of approach we have done also during our workshops with Harmonize. And I have to tell you, Harmonize, I don't have individual pictures as this one to Harmonize, but Harmonize have so beautiful feelings. Also aesthetically, it's much more roundable. I don't know how to say it. It's taking the shape of the surrounding margin. Harmonize is more soft, let's say, and very aesthetic. But also Herculite Ultra, you can see it in this image. It's very easy to put. I put it out here because the depth was not much, 2 millimeters occlusally, only enamel on top. So we are making cusps in order not the central vestibular, then the opposite cusp, mesiolingual, distolingual, and in the last part, the vestibulo, distal vestibular and mesio-vestibular cusp. We try not to drag too much to the two faces of the tooth in the same time because they are shrinking, of course. We can use also this occlusal tip from Compotixo. This is the one I love the most. I use it also with sonic fill, even if to sonic fill I don't need the vibration of the accessory because the material has inside vibrating activity and it's soft. But to this high viscosity composite, it's really magic to use this device Compotixo. Of course, the adhesive goes out when we put down the mattress. We transilluminate also buccally and lingually. And when we put out the mattress, we can take out with something sharp the extra adhesion, and or we can use the strips, of course. We Metafix, it's very has a very good adaptation cervically, but we have to pay attention on the occlusal part because over there we have to shape it manually, the composite. Over here the adhesive you of course comes to the mattress, so the adhesive is the one that is going to take it out very easily. Also in these kits, finishing polishing, they have some beavers burrs that multilamellar burrs that are good in orthodontic, taking out the brackets and composites, but also on these composites in order not to touch harmful the enamel. They are active only on the composites part, not only on the enamel area. And of course the last finishing and luster. For the luster, the finishing, the proximal opti-strip, oxide aluminum particles that are very active, and of course they have a region when it's not with particles where you put it the first and then you move it to finish the proximal area. What I love about this OptiStrip is that they have two types of high, let's say 4 millimeters or 2 millimeters. The OptiStrip with 2 millimeters, I use them a lot in the frontal area. And when I don't want to harm the proximal contact point, those ones are very good to have it in the dental office. And or the 4 millimeters now, because we had a higher surface, we use the 4 millimeter, of course. So when you don't have an adjacent tooth, you can use the big ones. And the silicone embedded abrasive particles, these brushes, occult brushes, are quite effective for polishing of the composites. Uh, Kerr with KaVo department, they have a very complex, multiple types of finishing and polishing devices. Maybe they are not so well known as they maybe could be, but they could be found in the market around. Then the finishing and the polishing that has been with the composite, with the nano hybrid Herculite Ultra. Taking the Harmonize that we are going to see has taken the advantages from Sonic Feel and Herculite Ultra. And Harmonize is the edge, let's say, of aesthetics and luster in and ergonomics of manuality in composites. Sonic Feel, it's the most efficient composite, I would say, on the market. The one that we hope we are going to use routinely as an amalgam replacement, ideal replacement of amalgam in the posterior region. I have to tell you that I have this device already installed in my unit from the beginning of my private dental office, because when it's posterior region, in many times I use this composite, because in 3 minutes you have finished with the filling. As you say, it's a very ergonomic unit. Those you can activate by your chair as a high speed, let's say, device. You need an adapter if you don't have a KaVo unit, but there is an adapter on the market. Over here you can see the composite that it's very shiny from the beginning, because they have an inside the activity vibration. Also the particles are uniformly distributed in the composite, so it's very shiny and smooth when you finish, before finishing and polishing of the composite. It would be ideal if you would not try to touch it too much during finishing, the during polishing, at least the finishing and polishing the material. Over here, the adhesive was an extra, as I told you about Metafix. The adhesive, of course, because it's shaped from the manufacturer, the matrix. This is going out with a pointed instrument immediately. Finishing, polishing with the same devices that I told you. So this is sonic fill adaptation to the cavity floor. This is the advantage of sonic fill. We don't need any more a flowable composite in conjunction with this sonic fill. What do we have now already that we are speaking is sonic fill 3. I have seen it last autumn in Germany when I have been to KaVo showroom, but I hope this let's say summer and autumn to have the first cases with this Sonic Field 3, to have this let's say shine that it's inside this composite, and the mechanical properties of this one. Even though I have from 2011 with Sonic Field, the first generation of Sonic Field fillings, I will show it to you, that are still very good. OptiBond XTR is the 6th generation. This is the first case of mine with Sonic Field in 2011 that I'm telling you. In an MOD cavity and class 2 cavities. It's an self-etch 6th generation adhesive. I used and I still use in my office this kind of mattresses. Right now I didn't have the time to put the images with all the, but it's over here. It's the super matte let's say cervical matrix that you can put it very straight on your tooth. You can adapt it a lot on your tooth if you want to loosen it or to make it more tight on the tooth. Of course, when you use sonic fill at the beginning, you are like a student, let's say, to not to have 4-5 millimeters depth when you put from one moment single layer this composite. But with time, you are going to see that most of the cases, if they're above the gingival margins, are 5 millimeters, not more. But when you have more than 5 millimeters to a non-vital tooth, let's say reconstruction of the coronal area, then you can put in two layers separately this sonic field. What you can see, as I told you, it's very smooth inside. On the YouTube, you can find many videos. I encourage you to see also Sonic Field 3, because you are many from Poland. I have seen to Dariusz, he put it also a YouTube movie on Sonic 3 clinical case application from a Polish colleague of us. So he's forward to me in using Sonic Field 3. So I encourage you to see that movie, to see the difference. Maybe Sonic Field first original one is more translucent, let's say. But in my clinical cases, this was not a bother for me, or not at all for my patient. From here, this patient of mine, in the second visit that she came, you can see the big wedges, sycamore wedges. If you have the assorted kit of sycamore wedges from Kerr, you have all the shapes of the papilla area that you want. From the biggest parodontal retraction situation to the pediatric patients that I'm telling to you. So I would encourage you, when you are not, let's say, you're happy with the wedges that you are using it in your clinical case use, or you're not happy with the adaptation of the proximal area in your fillings, or you don't have tight proximal areas, think about these wedges that are, from my point of view, the solution to all these proximal problems that you could have. Most of them, of course, problems. Over here, sonic field in the middle already to a 1 week distance, and then we have put it with OptiBond XTR, the self-etch adhesive protocol sonic fill in the other ones. So you can see I put it a lot of material in one step together with a self-etch adhesive. This was a kind of with emotions from my self, because I knew that it's not the best adhesion to enamel, let's say, and the composite in the first, but I knew the research that is saying that the layered composites, because this was an area of my PhD, are making a lot of stress. Each layer together after the end, if you put the values from the stress on the tooth and adhesive layer from each layered composite, it's in some products the same, but in some products it's higher the stress on the tooth when it's a layered composite versus a bulk fill composite. And in order to have a degree of conversion that could be a problem in a bulk fill composite, you are going to make the transillumination addition of light curing on your dental fillings. So over here, 3 fillings with MOD and 2 class 2 with sonic fill and Compotixo, but it was not helpful a lot with the vibration because he was soft enough, this one. But I like this very sharp Compotixo point of the instrument. And these are the images of my parodontopathic patient, let's say, with OptiBond XTR and sonic fill. She was with very high retractions, as you see. I avoided, and I was happy to avoid the acid etch adhesion protocol. And for my patient, there are already, let's say, 9 years. In that week, not even till now, my patient said she had no problems with these feelings, and no post-operative sensitivity linked to these feelings. Of course, this is my last 15 months post-operative sensitivity. Of course, when you have bruxism patients, maybe you have to pay attention. That's why the Sonic Field 3 has more mechanical properties now as the old ones. But it's very good to the tooth. These properties of mechanical properties of composites are going extraordinarily with the tooth around. Of course, with the composites, we have to pay a lot of attention with periodic hygiene on the patient. We were one of the first, I was one of the first dentists then in using sonic field technology, and I was to a European Congress, and of course, I was one of the first ones to use this sonic field composite. Um, this is another clinical case, but I'm not going to focus on this one. This was an endodontic post-treat restoration, post-endodontic restoration, let's say, with some old composite fillings, with some necrosis and some periapical lesions. Um, of course, we had to make the endodontic treatment. We have used easy system solution. This is it was from Spofa with resin cements, self-adhesive cement, easy chem and easy core. It's like build it from Pentron on the core reconstruction, of course. And we have used some posts from Pentron Spofa that are also composites. So also these posts, you should know, many of them are composites that are linking some some glass fibers inside for mechanical, let's say, properties. Let me for a minute, because I have a little guest over here. I'm going to finish it. So over here I have used in each tooth a different adhesive protocol. EasyChem on the core radicular part, a self-adhesive resin cement in the first part. And in my second clinical protocol, I used that easy core with an adhesive protocol added on the radicular part. This the lateral, it's with a self-adhesive resin cement easy chem on the radicular part, and this one with easy core on the coronal and radicular part. In the first steps, I used only the easy core composite for the easy core for the reconstruction of the front teeth, but I don't have it from the vestibular part. But afterwards, you will see some aesthetic reconstructions with Herculite Ultra. Of course, because it's a self-adhesive for the lateral, I didn't use any adhesive system. Then on the coronal part, because I had enamel, I have put the selective etch, acid etch of the enamel. And then with easy core on the coronal part. And then I adjusted, let's say, aesthetically with the Herculite Ultra. And to go with composites together with all the 6 adhesives from Kerr, OptiBond Extra Universal is a 9th generation universal adhesive with 2 bottles, and OptiBond Universal is a 1 bottle all-in-one adhesive. Of course, both of these, because are the last adhesives, are recommended with the last composite from this manufacturer, but not only, of course. All the adhesives from Kerr are working with all the composites from Kerr, and not only with composites, also with amalgam materials and also with compomers. So Kerr manufacturer is very flexible according to the other materials, aesthetic materials on the market. Harmonize, it has a new technology regarding the refractive index of the composite the tooth. About clinical cases, more with Harmonize, I can say I have seen my colleague Lupu Costin. He's the one that has made the webinar with Harmonize and adhesives. So on the frontal area, if you would like more tips and tricks, I would recommend you to show also his webinar on the frontal area. And you will see the use of many types of enamel dentin shades, the ones that are, let's say, I know them more from premise. So the ones that are used with premise, we are going to find some links also to Harmonize. Only the consistency is radically different. Harmonize is more soft, let's say, with a better manuality than premise. And our dentists in our hands-ons last year, we have started with Harmonize in the workshops, were very, very happy when using Harmonize with this. You have seen cusp reconstruction, successive cusp reconstruction in conjunction with Harmonize. So if you want aesthetic frontal and posterior reconstructions, I would recommend you Harmonize with this successive cusp reconstruction. If you would like aesthetic but not as easily shaped, anatomically shaped fillings, but in 3 minutes ready fillings, with good 10 years clinical data already proved with sonic fill, then I would go for sonic fill. I would recommend to have this bulky sonic activating bulk fill composite and a layered aesthetic composite in Kirk's case Harmonize. Uh, in my because the most dramatic, let's say, case of mine, I wanted to make a picture of him, even if it was a Sunday. I didn't. It was a friend of some friends, and it was with OptiBond EXTR reconstruction, and in self-etch mode, and we have already 1 year of retention of this harmonized 4-class composite with OptiBond EXTR in the self-etch 100 mode. So and he is still waiting to come. My patient is staying in another city. In the last time he said he's going to come, but he already has, I think, 1 year already with those feelings. Of course, you can. I use the no edge with the OptiBond Extra Universal, but you can use a total edge approach or a self edge approach. I didn't want it a self edge or a total edge because I wanted. He was sensitive. He has a traumatic situation, and I didn't want it to go on dentin anymore. Vortex Flow, it's another composite that I've told you. It's a promising first step uh, composite adhering, self-adhering composite on the market. He was a pioneer. Kerr was a pioneer for composite flowables, self-etch, self-adhesive flowables. And Vortex Flow, it's my composite for sealing pits and fissures on young molars, and I recommend it to have it in the dental office because it has a very good brush. I use it a lot. We have to use the first layer of Vertisflow as an adhesive, and then you put to have a real sealant in the pits and fissures of your tooth. Here I had 10 years, 9 years ago, 10 years already, 10 years ago, when Vertislow appeared, then I already use it. And I already have, but this is one of the few patients that I have from big clinics that I worked in those days. Now I have my own practice, but she came last year, and I had this radiograph after having a break because of also my children, and switching the dental offices, but they are still over there. The self-etch property, self-adhesive property on cut enamel, because there were little cavities on enamel, only with Vertis Flow retention on these molars, already almost 10 years. Almost 10 years. Over here, another image when Vertis Flow was used. But I have to tell you, I haven't seen this patient since then. But I use Vertisflow as an adhesive, over there. Um, I have to tell you, I put it enamel over here, but I could. It was a selective enamel of the margin, and I'm happy because it was. I have made that because there was big cavity, and I hope the patient is well. For a half a year, he was well till I was in that big clinic in Bucharest working in 2010. Was that? But the beautiful, it was very beautiful. No post-operative sensitivity, of course, because it was a self-etch approach on the dentin. Even this one on premolar was very deep. I put hydroxide calcium even now, and with Vertis flow over it on top. It's like a compomer. So Vertis flow was directly on top of the hydroxide calcium liner, and then I put it. I spread it more on the margins, enamel, and on top I put it Herculatic Cerve Ultra that you see over here. Uh, Mechanically speaking, from my point of view, Kerr is on top of composites. Also, aesthetically speaking, they have made big progress in the last years towards with premise, Herculite Ultra, and Harmonize more. And with Harmonize, they have harmonized, let's say, the aesthetic properties and the mechanical ones. Adhesion and mechanical properties are number one to care from my point of view. And this is it. Also, my voice can't anymore. I have to thank you, the ones that are still with me, that you have paid attention. Um, of course, thank you for passing the webinars on adhesion. Darius, if there are questions, Elisabetta, I also thank you. I like your name, Elisabetta. Also, Renata, nice to meet you, and hopefully to meet you also physically, not only virtually, let's say. And Yelena, I also thank you very much to all of you, to all your dentists from all your regions for all your promoting my event. And hopefully from better to better from now on. And I wish you all to keep safe and take care of each other. I don't know if there are questions. If not, I we will see each other more in this virtual area from now on. Also, to my let's say email, you can Ilic Caradent. You can pass me question, and I say bye to all. Have a nice day. Have a nice day.